Morning, everybody. I'm Hart Beatty at Boston Medical Center, and I do 25% emergency imaging, 75% neuroimaging at BMC. So, get a lot of experience in the emergency setting there. Goals and objectives: understand the anatomy and physiology of headache, apply that knowledge to explain referred pain, and identify causes of nociceptal and neurogenic headache in the ER. This was the question. We will get to that. So, headache. I mean, this is relevant to all of our lives personally and clearly relevant to all of our practices. Headache touches almost every subspecialty. Knowing headache and the physiology of headache can have a tremendous impact. And it's part of virtually every specialty. So types of headaches, guys, there's primary headaches that represent conditions where the headache itself is the problem and not a symptom of an underlying condition. That's primary. Secondary headaches are what I'm going to focus on today. And there's another cause for the headache. Okay. Now, typical primary headaches, there's like 17 primary headache disorders. And clearly, the most common are tension type headaches, migraines, cluster headaches. Those generally present with fairly classic clinical symptoms. They almost never need imaging, right? They're going to their primary care doctor. They're going to a headache specialist. They're not going to get imaging. If we think about migraine headaches, this is sort of a neurovascular process we've learned. Something called the trigeminal vascular system is activated. And these are trigeminal sensory afferents that surround cranial blood vessels. So you can imagine there's a perfusion problem here, okay? That perfusion problem is responsible for the aura that patients get. I mean, there are probably several people in here that have classic migraine headaches, right? And it's that hypoperfusion, hyperperfusion aspect of the vessel and almost a relative ischemia that causes in certain parts of the brain that end up causing the visual aura of a classic migraine headache, okay? So there's been a lot of talk on, can we image migraine headaches? If somebody comes to the ER with the history of headache and they get a brain MRI, is there anything on the brain MRI that might steer us towards the fact that this patient's experiencing migraine? Well, there's a couple soft signs, which I'll show you now. So clearly you see here that the diffusion scan is negative. If they do get an MRA, there's a talk of pruning of distal vessels. You can see the types and numbers of vessels here on the right side. There's a relative pruning on the side of the migraine with the vasculature. Now, if you look at your susceptibility weighted imaging, there's a little bit of vascular engorgement here that's venous. So you have arterial pruning and you have venous engorgement. You might see that asymmetrically on your SWI images. And finally, the perfusion scan shows relative hypoperfusion on the ASL. So if there's some stuff, even if you're getting just a typical conventional MR on some patients, you might want to look a little bit for venous engorgement. If you get an MRA, look for a little bit of pruning. That might steer you. And we've all seen, by the way, and on the FLAIR image, little FLAIR signal hyperintensities in the frontal lobes. That's relatively, I don't want to say classic, but we've described that in migrainous patients. Little FLAIR punctate hyperintensities predominantly in the frontal lobe. I get that in a lot of headache patients in the ER, and I say that can be seen in the setting of migraine headaches. That's usually what my impression says there, okay? So secondary headache disorders occur because of another pathologic process. Now, when do we image headache? We image headache when there's a chronic headache with new features. Something has changed in a chronic headache patient. They're either new features increasing in frequency, there's been a change in pattern. Also, sudden or new unexplained headache in this patient population. So there are times where we are going to image headache. Now, I want to emphasize, guys, this talk is not about head trauma. I'm not going to show you epidurals and subdurals and subarachnoids and all that. This is about the subtleties of headache in the ER. Referred pain coming from other processes. You have another talk this afternoon on head trauma. That's the obvious cause of headache amongst other terrible things. So I'm not even going to address I'm not showing you big epidurals and subdurals. These are going to be pretty subtle findings that may help you diagnose in patients. So imaging is not appropriate for most headaches, which are usually resolving spontaneously, and it's not appropriate in classic features of primary headache. So you should not be imaging them. This is a paper I'm going to refer to in some of the diagrams. I think it's really, I always loved knowing why things happen, right? We can memorize a laundry list of things, But if you can understand why referred headache happens, it's really going to help you with your diagnosis when you're sitting at the workstation. So this paper is the why, and I'm going to highlight certain parts of this paper for headache anatomy and physiology, okay? I want you to sit here and feel this in your own head and neck, okay? I'm going to pinpoint a piece of anatomy for you, and I want you to visualize that in your own brainstem, okay? Forget about the details, okay? So the trigeminal nucleus has three components: the mesencephalic, primary sensory, and the spinal nucleus. We're going to focus on the spinal nucleus. Working our way down, the spinal nucleus has three components: the pars oralis, interpolaris, and caudalis. Don't even worry about that, okay? Just think of this little spot in your brainstem. Don't even worry about what it's called, okay? Now, the pars caudalis has what we call, this is where the money is, guys, the trigemino-cervical nucleus. What does that mean? Break it up into its parts: trigeminal nerve and cervical. This is the place where trigeminal afferents from all over your face, the cranial nerve 5, intersects and overlaps with cervical nerves. That's all I want you to remember. There's a spot in your brainstem that has tremendous overlap between the trigeminal nerve and upper cervical nerves. And this is where crazy referred pain is going to happen. I'm going to show you how this works. But just remember that little spot in your brainstem that has tremendous overlap of nerves in your head and neck, okay? This is the afferents, the number of afferents this little spot receives. It receives afferents from your trigeminal nerve, 7th nerve, 9th, 10th, and upper cervical nerves. So much overlap in this one area from all around the cranial nerve and upper cervical spine. Just remember that piece of it. I'm going to explain why that's important. Now, again, all these afferents come together for referred pain, okay? And this is the crazy part about this. This is V1. It can go down to this area, right? And you can get an orbital headache. Because you have overlap of upper cervical nerves, you can have degenerative disease at C1, C2, and you'll get an orbital headache. It won't even manifest as neck pain. So there's such overlap that you have to be cognizant of all these areas in the head and neck and upper cervical spine for any type of headache. So an orbital headache can be coming from your neck. Neck pain can be coming from sinus disease because V1 might innervate your frontal sinus. Tremendous overlap everywhere, okay? I know it's a little bit crazy, and this is what it's showing. So pain in the forehead. This patient had pain in the forehead. There's two ways to get that. Well, many ways. You could have frontal sinus disease, or you can literally have degenerative disease at C1, C2, and that will give you an orbital headache because of the overlap, okay? So, as you go through this talk, I want you to just think of, wow, my checklist for headache now is getting bigger and bigger and bigger because we're always looking for the really serious things like bleeds, ruptured aneurysm, but now those subtleties of headache. Does the patient have sinus disease? Can I have a view of their upper cervical spine? Can I look at their TMJs? I'm going to show you how TMJ disease can give you headache. There's so much overlap all over the head and neck, okay? So here's the question. Why more often is temporal or orbital headaches happening? When we talk about V1, 2, 3 in medical school, guys, remember it was like, oh, this is the orbital division, this is the maxillary division, and this is the mandibular division. The trigeminal nerve is all over the place, and I'm going to show you. But the V1 portion of the trigeminal nerve goes way deeper than the V2 and V3. So it can take in more overlap and referred pain than V2 and V3. This is why you don't have more maxillary pain or mandibular pain. You tend to have more orbital pain because V1 goes down to receive more afferents from around the head and neck. Okay? I think you were asked about something similar earlier. So, so think about the trigeminal cervical nucleus. Okay, super important in that way. That's the one piece of anatomy. After all these words, don't worry about them. That's the one piece of anatomy I want you to remember, and it's embedded in your brainstem, and it has tremendous overlap. Okay, so let's consider the distribution of afferents. So pain can arise from, as obviously as you know, You have a neuron. Pain can arise from the nerve endings, okay? The terminals. Then you go to the cell body and then the axon. You can have irritation of the terminals, and then you can have direct contact of cell bodies and axons that will cause pain too. That's the difference between nociceptive and neurogenic pain. And then central pain we're not going to talk about today much, okay? But the other two types I'm going to talk about. So nociceptive pain, you are disturbing the nerve endings, okay? There are two ways to do that, guys. Disturb nerve endings. You can mechanically disturb them, or you can chemically disturb them. Sort of basic ways to think about this, right? But if you can move these things you can stretch them. If you have nerve endings in your dura, which I'm going to show you, and you're stretching the dura, that's going to cause headache. Think of all the things that stretch the dura. That's going to cause headache for you. If you have chemical irritation of the dura rather than stretching of the dura, that's going to cause headache. Think of all your inflammatory processes. That's where they're getting headache from. The chemical irritation of the dura. No. Okay? So neurogenic pain, like we talked about, is actual contact with either the cell body or the nerve. Let's think of an example of that. Trigeminal neuralgia may be vascular contact of the actual nerve, right, in the cisternal segment. That is going to be neurogenic pain, not nociceptive pain, because we're not dealing with nerve endings, we're dealing with the actual nerve. Okay? I'll give you some examples of that later, so I'm not going to talk about central. So the periosteum and the calvarium, guys, extracranial headache is being talked about a lot. These things that stimulate the scalp and the skin in the scalp, some of you may be experienced, scalp headaches and things like that. These nerve endings come down to the periosteum of the calvarium. So when you talk about the skull, this is very important. It's the periosteum that causes headache, not the diploic space, but the periosteum of the skull. So, because this is very important, guys, if a patient comes to the ER with headache and you notice one of these things in the skull, it probably is incidental because it's not involving the periosteum of the skull. This is just a venous malformation, even an epidermoid. We're not going to say things are malignant, guys, in the skull. Like this is a metastatic lesion just because the patient has a headache. Headaches are so common, but if they are not involving or eroding the periosteum of the calvarium, this is not likely the cause of their headache. Okay? So be very careful about that. So don't let classically benign appearing lesions sway you if a patient on a patient with headache. They're almost invariably incidental. Okay? Painful things doesn't also mean malignant. Look at fibrous dysplasia, right? They can be painful. Look how they're involving the periosteum of the calvarium. These are painful things, but they're not necessarily always malignant either. Again, they're involving the periosteum of the calvarium. Okay? So let's talk about V1. As we know that classic distribution, orbits and eyes, frontal sinus, anterior cranial fossa, and falx, this is the thing I want to show you. This is a mechanical cause of V1 pain, any type of mass. Retrobulbar tumors. This is an ethmoid mucocele. All the stuff you can imagine in the V1 distribution is going to cause pain. Inflammatory causes or chemical causes, all of your diseases like, optic neuritis, uveitis, all your infectious inflammatory things are going to be a reason for headache. That's a chemical disruption, right? We had great cases of this in Will's talk yesterday. IOIS, this is an optic nerve sheath tumor. Again, these are disruptions of the V1 distribution that can cause headache. The dura. So this is the thing that most people are not aware of. Again, we talk about the orbital division of the V1. The innervation of the dura is really extensive, and I'm going to show you that. So stretching of the dura can cause mechanical disruption, and I'm just going to show you from the anatomy. This in the gray, guys, or the purple, is V1, innervation of the dura. And look how far back that goes. This is all V1, the gray. This light blue is V2, and this is V3. So your entire dura is innervated by your trigeminal nerve. I go back to this gray, and all of this is V1, innervating your dura. So you imagine if you had a posterior fossa tumor, that could be an orbital headache for you, right? Because the extensive innervation V1 has all over the dura and the rest of the trigeminal nerve. And you can see here, even like, down here are your cervical fibers, C2-3, right? So posterior fossa headaches, a lot of us are like, oh man, the back of my head hurts. That could be degenerative disease of your spine doing that, because that's where it comes up, where the dura is being stretched, or vice versa. So the tremendous overlap here. So that's one thing that most people are not aware of. So this is why you have tumors stretching the dura causing headache, okay? And that can be for other reasons too. Space-occupying lesions, intracranial hypertension, and we'll get great talk on intracranial hypotension. You're stretching the dura. When the brain sags, you're stretching the dura, and that's causing pain. Brain tumor, by the way, headaches are frequently the initial and only symptom of certain tumors. Only 17% of people with brain tumors present with the classic features of morning headache. They tend to be morning headaches with vomiting, okay? Kids, it's a little bit different. They usually have posterior fossa tumors, and they have like unremittent vomiting. If you hear of a child with symptoms, they're constantly vomiting, you're really worried about a posterior fossa tumor on those kids. This is probably one of the most important slides I'm going to show you today, and Will alluded to this yesterday in his talk about hypotension. If you have a patient with headache and you happen to have an MR at your disposal, go to the midline sagittal T1, and I'm going to show you how to differentiate 3 different entities that are very important. You have idiopathic intracranial hypertension. Now, one thing all these 3 entities have in common is downward herniation of the cerebellar tonsils. The configuration might be a little bit different because these are pointed and these are somewhat rounded, I'll give you that, but they all have downward displacement of the tonsils. So how do we differentiate these 3? We know that with hypertension, look at the sella. It's almost always a partially empty sella, right? They'll have other findings as well. In hypotension, we have plump sella, a larger than normal, an engorged sella, an engorged pituitary, and in the Chiari, it's normal appearing pituitary. So the pituitary can be a real hint for you on what you're dealing with here. Why is that important, guys? Listen, this here has been called Chiari before, intracranial hypertension. And they have done occipital craniectomies, and people are just getting meningoceles like crazy because they actually had hypertension in their brain. And they decompressed this thing thinking it was a Chiari malformation. And the complications are crazy. So you never want to misdiagnose hypertension for Chiari malformation. That could result in significant complications. Now, mind you, the symptoms will be different too, right? Chiari malformation is usually a Valsalva or cough-induced headache. The neurologists, neurosurgeons are looking for that. You bear down, you feel worse. Hypotension, as Will talked about yesterday, is positional, right? You get up, 15 minutes later, probably you're starting to feel a tremendous headache. Hypertension, also different. You have blurry vision, pulsatile tinnitus, all these associated symptoms with that. So the symptoms can help tease this out. But if you don't have the luxury of that, be careful about calling everything Chiari, right? Because if they decompress that, you can get into serious trouble with the other 2 diagnoses, okay? I showed this case yesterday, very important. Whoops. I made this point yesterday for some of the group. Mucus retention cysts are very common in the sinuses, but think about the sinuses that are not attached to brain. The maxillary sinus is not attached to your brain. The frontals are, the ethmoids are, and the sphenoids are. If you see a mucus retention cyst in any of those sinuses, that could be a meningocele coming from up top in patients with high pressure or hypertension. So never ever blow off a mucus retention cyst in the frontal sinuses or the ethmoids or the sphenoid sinuses, because those are attached to your brain. And you got to make sure that's not a meningocele or an encephalocele coming from above, okay? This is a good case of that. In 2019, we have this. It was very subtle in 2015, and somebody called this a mucus retention cyst, and look, that's a dehiscence in the skull base there in a patient with hypertension. Looks okay here, but now you're starting to get dehiscence here in a patient with hypertension a couple of years later. Similarly here, optic nerves are tortuous, empty sella. There are arachnoid pits along the inner table here and arachnoid pits at the skull base. That's high pressure pushing on bone and remodeling bone, okay? I do want to mention one interesting thing about optic nerve tortuosity. We're all looking for that for our hypertension patients. There are papers that will say it's not axial tortuosity, it's not on your axial images, it's vertical tortuosity on your sagittal images. That is more specific for hypertension. So vertical tortuosity may not look that bad on your axial images because it's kind of coming in and out of the plane. But if you look at your sagittal, you're going to see some serious angulation, So it's vertical tortuosity that's actually more specific for intracranial hypertension than axial tortuosity. So when I'm looking at these midline sagittal images, I go to the orbits also to look at the optic nerves. I just scroll over to the orbits to see if there's any vertical tortuosity, if I'm entertaining the diagnosis of hypertension. Just keep that in mind, okay, guys? Okay, so again, chemical causes of dural irritation, we're pretty comfortable with this. Anything that causes inflammation or infection of the dura is going to cause headache in that distribution. This is just an example of skull-base osteomyelitis, another thing that will do that. Vascular causes. So when we have spasm, that's going to cause headache, right? Vasospasm. There's several ways to get vasospasm. But it can be caused by drugs, caffeine, other things. Classic worst headache of my life. This is the one case I'm going to show. Ruptured aneurysm. I always tell my trainees, arteries love blood in them. They hate blood around them. Okay? If arteries have blood around them, they're spasming. And that's going to cause headache. That can cause stroke. That can cause a lot of things. So this is the mechanism why which arteries start spasming. They get irritation around them. Okay? The other diagnosis is RCVS. Okay? And reversible cerebral vasoconstrictive syndrome. This can mimic aneurysm subarachnoid hemorrhage. It's a thunderclap headache, and it can be caused by a lot of agents and induced by a lot of things. So the difference here, guys, for RCVS, we're very comfortable with subarachnoid hemorrhage from aneurysm rupture being at the basal cisterns, ACOM, PCOM, MCA aneurysms. RCVS subarachnoid are peripheral. They tend to be cortical. We used to call this Call-Fleming syndrome. There was a lot of names for RCVS tossed around, but they're going to have peripheral subarachnoid hemorrhage, and that's going to be very odd why this and that. But if you see that, you want to get a vascular study like a CTA to look for a spasm in the distal vessels, okay? So this is, I hope you have these in your notes, but aneurysm versus RCVS, subarachnoid hemorrhage is more common in the basal cisterns. The presence of increased intracranial pressure and hydrocephalus is more common here. This is narrowing a smooth and long segment, and it typically involves the proximal vessels. This is very different than RCVS because the vasospasm is more peripheral, and there tend to be areas of dilation and stenosis rather than smooth tapering. And this is an example of that, where you see distal vessels, there's narrowing, there's tapering, segmental tapering of that distal vasculature in RCVS. They can have exertional headaches, sex headaches, all these are causes of RCVS, okay? Again, chemical causes, we're starting to get more of the cadence here. Any infection, inflammatory process can do that. So let's get into the V2. Nose, paranasal sinuses, upper teeth, and I showed you the dura that's innervated by V2. Clearly mechanical causes, chemical causes. You hear the cadence now of this lecture, right? Think about stretching of the dura and irritation of the dura, stretching of nerves, irritation of nerves. Maxillary sinus squamous cell carcinoma, headache is the least of their worries here. I'll admit you that, but it can do that. And even chronic sinus disease, this is just an aspergilloma, and that can cause headache, right? So always look for these types of causes of headache in your patient. Once you have ruled out the really, really severe things like subarachnoid hemorrhage, now you're going into this checklist of what else could be causing this patient's headache? How else could I help this patient potentially? Because headache, come on, guys. Headache can be like the worst thing you're experiencing on a day-to-day basis. But if you can catch one of these subtle diagnoses, you could make a significant difference in the patient's outcome, okay? And V3, dura, the middle cranial fossa, we showed you lower jaw and teeth, ear, TMJ, muscles mastication, even TMJ disease. This is a sort of a dislocated disc. We're not getting TMJ MRs in the ER, I admit to you that, but if you happen to notice one of these could be the cause of headache also. What I do, though, I will admit, in the same way I'm looking for upper cervical disease, literally on my head CTs, everybody's getting coronal reformats. I check for TMJ disease on my coronal head CTs for headache because that could be a cause. So I'm looking for anything as I'm scrolling through. But I actually do look at TMJ disease as a cause of headache after I've ruled out all these very serious things, okay? And everybody has a head CT that includes that on their coronals, okay? And obviously, chemical irritation. So I just want to go into these other sort of smaller areas, which can be kind of interesting. Cranial nerve 7 and 9, the things they innervate. Again, mechanical causes and chemical causes. You're also going to look for local features in some of this stuff. You're familiar with Tippich syndrome, sort of inflammation of the arterial wall, usually the cervical ICA. ICA aneurysms can do this. So again, anything involving the ear. This is a right EAC cholesteatoma that can cause headache. Middle ear disease can cause headache. I will say, the one thing I want you guys to be careful of, we talked about this in our sinus talk yesterday. So certainly air fluid levels in the sinuses can cause headache and stuff, but be careful on calling air fluid levels acute sinusitis. I know there's a lot of push to do that. I mentioned yesterday, they did a paper many, many years ago in an ENT study. Everybody who presented with sinus symptoms, they got CTs of the sinuses on, and many of them had air fluid levels. They did not treat a single one of them, and they re-imaged them 2 weeks later. All of the air fluid levels were gone. Okay? So please, do not call all air fluid levels or even pneumatized secretions, we call them pneumatized secretions or bubbly secretions, acute sinusitis. That's more of a clinical diagnosis. In the same vein, I will say, when you have, so the terminology I use, I'm sort of very specific about terminology. I don't call fluid in the mastoid air cells on CT, right? You don't know if that's fluid. I just say opacification of the mastoid air cells, because that could be a cholesteatoma in there. It could be a number of things sitting in the mastoids. But if there's opacification of the mastoid air cells, please don't call that mastoiditis. That is a clinical diagnosis. They should be looking for that. And that forces the hand of the ENT to come down to the ER and start evaluating literally every fourth patient for mastoiditis, right? So that is a clinical diagnosis, and please do not push that diagnosis just because you see opacification. If you have a T2 weighted MRI and it's bright, I'm comfortable calling fluid in the mastoid air cells there because it's bright on T2, but I only say opacification on a CT exam because I'm not sure what's sitting in there necessarily. It's probably fluid, of course, but do not call acute mastoiditis and do not call acute sinusitis because you see those things, just as an aside. So C1, C2, sort of more interesting nerves. They don't emerge through the vertebral foramina. They're sensory to the suboccipital muscles. A lot of people experience occipital headaches for similar sort of physiologic and embryologic reasons there. C2 crosses the posterior aspect of the lateral axial joint. So this is why when people are experiencing cervicogenic headaches, they're doing nerve blocks behind the C1, C2 joint, and that's like really, really improving their headaches because that's where the ganglion sits. So C3 is actually your first typical spinal nerve, okay? So again, this is part of my checklist: mechanical, chemical causes. Again, you have space-occupying disease, vertebral artery disease, and then synovial joint disease in the upper cervical spine. So I'm always looking for that. A couple of examples: vertebral artery dissection. We know that gives that classic occipital headache. And then TB meningitis. We had an attending who was experiencing occipital headaches. We couldn't find a reason. She said she went to an amusement park the weekend before and rode a roller coaster, and her head was really jarring back and forth. She was experiencing the unremitting occipital headaches, and she had vertebral artery dissection from the roller coaster. So that can happen. Neurogenic pain, just a couple quick thoughts on that. Again, this is affecting either the cell body or the axon, and it usually is in the distribution of the nerve that it's affecting. So a couple very classic examples of that, I'll say, are the cranial neuralgias. Most typically, it's trigeminal. It's that classic sensory trigeminal nerve pain. You can have a lot of causes of that, but we're always looking for that aberrant nearby vessel on our MR examinations. Just a quick peek at that. This patient experienced left trigeminal neuralgia. This is that little vessel that's contacting the root entry zone of the trigeminal nerve. And then obviously you can have that chemical irritation. This is Petrus apicitis and Gradonagos syndrome because the trigeminal nerve crosses the roof of the Petrus bone. So a couple things there. This was one of the more interesting things when I was giving this talk. I kind of researched this a little bit. Cranial 9 or glossopharyngeal neuralgia. Cranial nerve 9 has all these sensory roots, and it's motor to only one muscle in your neck. But the sensory roots of the posterior tongue, pharynx, middle ear, you can experience a lot of paroxysmal pain. So when people talk about electric shock-like pain affecting their posterior tongue, pharynx, tonsillar fossa, deep in the ear, it's this really sharp stabbing pain in the back of your mouth that they experience, and that's irritation of the glossopharyngeal nerve. And there are other things, provoking. You can provoke it by swallowing, yawning, things like that. But some of the entities, and we've actually made this diagnosis in several patients. This is Eagle syndrome, which is these very elongated, ossified stylohyoid ligaments that irritate the glossopharyngeal nerve and can cause this paroxysmal pain in the back of the mouth and base of the tongue there. So there's a lot of reasons you can get that, but that's just one thing that I thought was very interesting. The last thing I'll add again is that upper cervical spine disease that I really hope that you look for when you have patients experiencing headache. And this is just the concept of cervicogenic headaches, okay? So, and there are obviously CT-guided blocks that you can experience. The last entity I want to just mention to you is calcific tendinosis of the longus colli. We showed this yesterday. A large, dense calcification underneath the C1 arch causes a retropharyngeal effusion. This can also irritate your upper cervical nerves and present with headaches. So, and then the takeaway points here. So I hope this helps you with your checklist. I know it's extensive, but if you understand the physiology behind headache and the overlap, they may help you make those diagnoses in the ER. So thank you very much.